how do you protect environments where work is being done in the OR or in pharmacy or some of these other more crucial areas, such as in long-term care. So this is where you have to think outside of the box, use your resources, reach out to vendors and ask, how can we circumvent this? How can we create a recirculating box so we can double HEPA filter and at least we can create a negative air pressure environment?
Infection stops where information starts. Welcome to the Transmission Control Podcast, where knowledge is your strongest defense. Broadcasting from the front lines of healthcare, we dive into the strategies, science, and stories shaping infection prevention today. Each episode, we connect you with experts on real-world insights to help you stop the spread of healthcare-associated infections, protect patients, and strengthen your practices as an infection prevention and public health expert. When the right information reaches the right people, lives are saved.
Hello and welcome to the Transmission Control Podcast. My name is Garrett Hollenbeek, Editor-in-Chief of Transmission Control. Today we're talking with Emily Barnard about how to navigate a victory lap in a critical access hospital. We'll talk about leveraging vendors for educational resources and additional support, how we prioritize everything from the microscopic to the macroscopic organisms, and how we keep prioritization in line to make sure that we have one victory right after another. Stay tuned after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Welcome to the Transmission Control Podcast. My name is Garrett Hollenbeek, Editor-in-Chief, and I'm joined today by our co-host, Jill Holdsworth. Jill, how are you today?
Hey, Garrett. I am doing great. Excited for this episode.
I am too, and it's always fun when we get to talk to people, one that we meet in person. A lot of our content lives on LinkedIn, so it's great to have our guest today, Emily Barnard, on. And I met Emily at the last APIC conference, and man, you talk about somebody that knows everybody and is involved in so many things, including her own podcast coming up here in the next few months. So Emily, welcome to the podcast. Thanks for being on.
Thank you so much for having me. I'm Emily Barnard. I'm Infection Prevention Manager at Mountains Community Hospital. I definitely am diversifying and excited for this new podcast as well. And I'm excited to join you for this one. Mitigate This will be something very unique and offset, looking at everything from the biology to public health, community health, infection prevention, sterile processing, and everything in between. So I think the first episode is going to be really fun. It's looking at brain invasions, bugs that really kind of attack the central nervous system. So that's a little bit about me. I've been in infection prevention for about 7 years and having a nice, exciting opportunity moving into leadership roles.
And like you, Garrett, I finally got to meet Emily in person as well this year at APIC. And all I have to say is, wow, what a ball of energy. It was so refreshing and just awesome to meet Emily in person. And we were both kind of like so excited when we saw each other. And it was just really cool.
I have to say, I did fan guy a little bit over both of you guys because it was just so exciting to meet you in person. You have such rich content and you're so engaging, and to really meet the people that you're connecting with, you're following, and, develop these new connections and that phone a friend. It's such an awesome opportunity to connect, and we can connect personally via text, phone call, LinkedIn, and whatnot. So definitely making those connections is one of the best things about going to a conference in person.
And it's also one of the best things about our industry and what we do. It really makes you feel like you're never alone. You never have to go through something alone, no matter how good or bad something is that's going on. we're all here for each other. And I think that's one of the coolest things about our industry.
One of the really nice things is being able to take away some of the stigmas of an issue that you might have at your organization and really be able to talk openly. Confidentiality, of course, is maintained, but really trying to find a unique solution into these specific areas. It could be the healthcare built environment. It could be challenges in sterile processing or different areas where you need somebody's unique knowledge base that you may not have. Again, looking at it from a different perspective really does help solve some of these solutions.
Yeah, it really does. And that's especially when you see kind of a unique environment of care, like type of hospital. So critical access hospital, which we're going to be talking a lot about today, is one that some folks in the audience may have a ton of experience with. They may have no experience with it. And when you find somebody that's a great resource in that space, it's invaluable because nobody's going to know everything in IP or otherwise, but everybody knows something. And so really what we found awesome about when we got to meet about to discuss this episode was your perspective of coming into a critical access hospital with an IP program that had some opportunities and how you've just kind of uprooted and gone ahead, addressing these gaps, having these individual victories, and really elevating the standard of care. So with that as kind of setting the stage, talk to us about what the status was when you came into your current role as an IP.
So I'll first talk about the transition from academic medical centers to a regionally isolated critical access hospital. It's very interesting because people are pulled from different areas to cover multiple roles. So sometimes you may see gaps and opportunities in the information that we're bringing. So this is where you must have that multidisciplinary approach. However, many smaller hospitals can find it easy to fall into these silos and where it's easy to stay in your lane. And infection prevention, we don't really have a lane. We kind of go into everyone else's. So before coming in, there was a gap of about 2.5 years of having a dedicated infection preventionist, really looking at how do you target that information. One of the ways that I did it was looking at a Gemba walk, just going everywhere, seeing where the work is being performed and going through these different stages to really operationalize, but seeing what's happening and where the gaps are first. First, I had to start talking with leaders and I had to look at what we were doing and how we were doing it. We didn't have a hand hygiene program. We didn't have some of these other things that you typically see as some of the core concepts of infection prevention. So it was an interesting process.
Emily, talk to me a little bit more about the Gemba walk. Some people listening may not have any idea what I just said or what you just said. Talk to me about what that means.
This is an amazing opportunity to talk about this. Thank you so much. The Gemba walk is part of a Six Sigma process improvement model where it was actually designed by Toyota, where you go to where the work is being performed. You don't use any judgment. You come in asking questions, open-minded. You take down notes, you circle back with leaders, and it's a cyclic process of improvement. This is something that where you really have to see what are some of the barriers. Is it perceptions? Is it a physical barrier? Is it a knowledge barrier? What is leading to the practices that you're currently seeing, and how do you find the gaps? Oftentimes, what you think is the easy root cause analysis component, it's actually multiple kernels down the way. Another way somebody may look at it are the 5 whys. And again, the Gemba walk is that opportunity going to where that work is being done versus making perceptions or assumptions about what's happening in that area.
It's such a great explanation, and it really gets you to the answer that may actually work, because you can't make action plans. You can't come up with solutions from your desk. And I know a lot of leadership teams use this method because if you come up, say you come up with a solution from your desk, you never go out into the hospital at all. You just come up with some random solution. It's probably not going to work because you didn't see anything that happened. You didn't talk to anybody. But if you're actually going out there, you're talking to people, getting opinions, and actually seeing the workflows, you're going to have a much better perspective of something that might work and stick. You know, that's something we always talk about. How do we sustain these changes? So thank you so much for that explanation. That was really great.
And that really applies when we think about splitting FTEs between multiple sites, because just because we have fewer beds in that particular facility doesn't mean that it's going to take half the amount of time to run down a particular issue. And taking the time to do the Gemba walk in that space may take significantly more time than an academic or acute medical center. And so it's one of those assumptions that's probably worth challenging, of just because you have a lower bed size doesn't mean that you're going to need a more limited IP staff to really address these issues.
Thank you for bringing that up. That's one of the things that it's so important to talk about. I'm a 38-bed facility that is split between rural health clinics, rural dental clinics, as well as long-term care and acute care. We also have surgery areas. Within that scope, it does make it very challenging because you are an educator. You are doing all these different things. You're also supposed to be that full-time dedicated skilled nursing infection preventionist. And you're working specifically with all these different teams. You're pulled in so many different directions. Sometimes your priorities may differ from administrative or other leaders' opportunities because their priorities, the way that they're risk assessing their areas, may be a little different. And then also new perspectives coming in, looking at opportunities. Again, going back to that Gemba walk, going back to that judgment-free zone, making sure that you're approaching things in a very gentle but firm way to explain why there are concerns, why we need to move things in the right direction, why maybe shifting from one direction in sterile processing to really looking at those IFUs or some of those other aspects.
Those are time-consuming activities to accomplish. When your focus is split between multiple areas, all of that requires depth, and it requires research on your part, any IP's part, to really know what the right course is going to be. And this applies for just the infrastructure of the building. So can you talk with us a little bit about some of the opportunities you've seen where it comes to construction or infrastructure? Because that's an area where IP is like, I would love to fix this, but it means taking out this wall or totally refitting a space. And what's been your approach for those really big lift challenges?
So first, you have to look at the healthcare built environment. What are the limitations of this facility? So this is an old facility. Thinking about ICRA 2.0, this is the direction that many facilities want to move in. And even the Joint Commission director really looked at saying, hold on, let's really think about, are you ready to move? This organization, we are not set up facility-wise based on the healthcare built environment, which means our facility infrastructure has limitations. There's areas where we don't have an HVAC system. How do you exhaust when you don't have an HVAC system? So how do you achieve that class 3 level of an ICRA? That's the infection control risk assessment. How do you protect environments where work is being done in the OR or in pharmacy or some of these other more crucial areas, such as in long-term care? So this is where you have to think outside of the box, use your resources, reach out to vendors and ask, how can we circumvent this? How can we create a recirculating box so we can double HEPA filter and at least we can create a negative air pressure environment? Some of the challenges really come with education and educational offerings in these environments. Thinking about access to ICRA training or whatnot from facilities. Who's doing the contract work? Is it facilities or is it a contractor? And thinking about their knowledge base as well. I would definitely say one of the big challenges is trying to fit all these best practices into an area that doesn't really fit that box. And I see you. I understand what you're going through. This could be the sterile processing area that has one single sink. How do you do your reprocessing in one sink? How are you doing your construction in some of these different areas? How are you ensuring that during hot and cold seasons, you have adequate airflow in an area that doesn't have airflow? This could be looking at your skilled nursing area and in-window air conditioning units. Risk assessing, making sure that we don't have the potential for Legionella or some other components, such as bringing in particulates from the outside air, such as aspergillus, or if there's construction activities, silica that may be disturbed, or lead, or any type of those other environmental components.
Emily, I have a question. You mentioned leaning on vendors for education and assistance, when you're in a rural area, how does that differ from major academic center or somewhere that's in a more populated area? Do you have the same type of access to vendors? Are they able to get there as quickly, or do you have to schedule them out a little bit more?
I'll definitely say I am so grateful for the network that I have built. This is a network of professionals as well as industry experts that actually are vendors in the field. I will say because of those relationships, I can have a phone call and ask somebody, hey, I'm in a sticky situation. Are you available? And if they're not, and I've actually had, I want to give a shout out to one of the vendors that there's multiple vendors that I've actually called and said, are you near me? Can you come today? I need support. Well, how about tomorrow? Does tomorrow work better for you? And I've actually had people drive up a mountain, drive 3 hours to help us in a very limited time. This could be something from fixed building infrastructure, such as a sink that needs to have components replaced from a 1950s scrub sink, to the adequate wipes, looking at, do we have the right bleach wipes? Do we have the right disinfecting wipes that we're needing for this specific thing? Dressings for central line kits. Really looking at who are your vendors, and also sometimes tracking down your vendors can be really hard. This is where you also have to rely on those infection prevention contacts. Looking at one person who has a connection and then getting down to your regional locale that really helps you get them. Those vendor connections are so valuable because, especially as a solo IP, I don't have time to do all the education, and I'm not always the subject matter expert. So getting a vendor in to do some of these different components, they've actually been very grateful and come up within a day. They're very excited, and creating the opportunity for having their presence is destigmatizing some of what you see in the large medical centers. Large medical centers, there's oftentimes this barrier between you're a vendor, you want to sell me a product. The vendors are so much more valuable than just a product. Oftentimes they are the subject matter experts. They've got connections to the subject matter experts. And sometimes you can work your way up the chain to find a unique solution, such as TEEs, and trying to figure out processes before the TIR 99 comes into place. So I know this is a little all over the place, but what I mean by that is lean on your vendors. Your vendors do provide a valuable resource from everything from EVS all the way up to construction, sterile processing, and everything in between.
I think that's such an important call out because especially when we're resource limited and staffing, those are almost, I don't want to say free FTEs, but they can, fill the gap a little bit. And in some ways, in my experience, a lot of those vendor contacts, especially the ones that you develop kind of close interactions with, they're clinicians that have moved into the vendor space. They're not salespeople that know about healthcare. And sometimes that's the case. And that's, and that's one of the challenges, I think, and something that would be great to hear your perspective on is when we have vendors come in to support, I think IPs sometimes worry about, are they going to say something that's misdirective to the staff? And how do I fact check that or audit that to make sure that they're not running buck wild, even as a trusted partner?
So this is where I think it's very valuable to be present for these different in-services. This also helps your knowledge base. Sterile processing is one that I can definitely think about. This is one where you can have your vendors come in. They can talk about their product. They oftentimes know where that research comes from. But sometimes also you could be present where there's misinformation that's being translated. And this is where you can provide direct support to the team that's hearing this information, such as a product that maybe has something specific in the instructions for use, or even that's spoken to in some of the standards and regulatory guidelines. Looking at some of those, if you understand as the infection preventionist the components behind that, you can help correct the education in real time. And that way you're not following up later and figuring out, well, how did we implement this process? In addition to that, they can educate you. Again, I will definitely say I don't know everything, thinking about how many wipes does it take to clean a room? Well, I don't know that, but there's a card that tells you, wait a second, how do we get this? So again, you can get free products that can help you be more effective. And then also working with your other leaders and connecting them and realizing maybe we might not be using the right products. Maybe this is how we look at our SDS, the safety data sheets. This is how we look at how we're implementing some of these products and also going to the end user to include them in that process. So I think definitely bringing in a vendor support, because there's so much more than selling a product. The people that come talk to you, they oftentimes were clinicians, they were nurses, they were infection preventionists. They did something in the industry, which is what brought them over, because they care about patient safety and healthcare quality.
And one thing I used to always do before and in service, as long as I knew about it, was provide that person with our policy related to whatever they were going to in-service on, to be sure they taught to our policy, because some things can be taught one way, but wait, this is our policy on it. And if they're not teaching to our policy, then it really kind of messed you up when you're trying to teach. So making sure that any kind of educator has our policy and they stick to that is really helpful.
That's an important one too, because it makes me think of one of the conversations we had last season about how overly restrictive or overly nuanced policies can get people in trouble. Because you may have something that's correct in your policy, and you may have something correct in what is being taught, but we have to make sure those mesh appropriately so that the staff has a pretty clear vision of what they're supposed to do. And that's the piece that becomes challenging when we have, as you highlighted, Emily, a long gap between somebody kind of at the steering wheel in IP, and then we get that kind of old saw that we hear, we've done this for years, it's never caused any issues. And I think you mentioned an AC, in-unit AC window, well, that's been there for years. Nobody's gotten sick from that. So how do you go about challenging and presenting data, investigating those processes for why some of these changes need to come about?
So I'm going to take a step back for just a moment and really think about education. So in a lot of medical centers, that's one of the things that's really important, is that people are going to conferences, people are going to these professional and connected to these professional associations such as healthcare engineers or infection prevention with APIC, HSPA for sterile processing, CHESS when you're looking at EVS. Now, one of the things that I noticed coming into this organization is that wasn't a tenant that was really promoted. People didn't go to conferences. They didn't participate in these different organizations, and this wasn't a priority. Now it's constantly looking at, if there's a conference, maybe you should be going to AORN or wound care or some of these different conferences that really benefit not just that one specific subset that's coming up, but maybe including your administrators or infection prevention. So going to look at specifically the air conditioner window units, really looking at where are we? So part of the infection control risk assessment and infection control plan really looks at multiple factors. What's going on in my community? What type of air quality do we have? Really surprising that Lake Arrowhead has the 17th worst air quality in California. The city it's on top of a mountain. You think that the air quality is great. Yeah. You think about the dust that's being disturbed and the road work that's constantly being done and construction debris and whatnot that may be happening in your environment, in addition to potentially aspergillus that's in your trees and whatnot. As you think about that, this air is being pulled in from the outside, where most healthcare organizations almost turn into this hermetically sealed environment where all the air that's coming in either has an air curtain that's preventing bugs or debris from coming in from the outside, or you have recirculating air that is being purified. This is something where you really have to think about how are you managing safety. So if a room gets too hot for somebody who's older and can't thermoregulate, how do you promote adequate health? You have to look at the risk assessment of using this device. And so this is where it's not necessarily best case, but you have to look at the safety associated with it. With this, I went back and I looked at assessments that were done of these previous units. How often were the filters cleaned? Was there any leaking, or was there any potential risks to the environment, to water damage, water intrusion from some sort of drain that wasn't appropriately placed, or we are in an area that rains and snows. So thinking about how does that affect things, as is this a avenue for different water intrusions, bugs, can animals get through, can pests climb through from an open window or whatnot, because we do have roll open windows. As you start thinking about some of these things, you really have to look at it from a multidisciplinary approach. Looking at what is best practice, what is the layer of likelihood? What is the severity versus likelihood? That real risk is so important. And this is why we currently have them. However, looking at future state, there's an opportunity to shift away from that. Again, by using knowledge base, by using evidence-based practice, by using new standards and guidelines, and industry professionals who are able to speak to how do you mitigate this? How do you look at this? And how do you move forward with lead time and these different components to bring in new infrastructure to your facility? Understanding that these are capital investments. This isn't something that's going to occur overnight. I live in California. So taking a step further, we have HCI, formerly OSHPD, which really restricts how things are implemented in the healthcare organization. But this is because things in the healthcare organization oftentimes were not done correctly. And now there's an additional oversight that's looking at healthcare equity and inclusion to make sure that the people who are going to be in these areas are safe, making sure that it's not just a patient and resident issue anymore, but it's now also a healthcare issue for staff members as well, making sure that we're not contaminating our ducting systems by how we're discharging our air and whatnot from a construction zone. So really it comes down to risk assessing and looking at the attributable harm.
I think that's a great approach. And I keep saying that everything you say is great because it is. Because these are real issues that critical access hospitals, acute care facilities are dealing with, is how do I connect the staff to the education, whether that's through a conference or a vendor or a study or something that you have researched and shared with them. And then how do I connect that education to the real world impact through Gemba walks and looking at previous survey results? And then how do I put that into a realistic timeline? And I think it's probably reassuring for our audience members to hear that you're not going to tackle everything in one day. There has to be a realistic stage by stage, step by step approach to tackling these massive issues. And I think that's great to hear because we want to just say, I'm going to fix everything this year. 2026, I'm going to have no issues that a surveyor is going to find or going to impact my patients. But we have to be kind of measured about our approaches so that they can be sustainable.
It's blowing my mind that you're having to deal with potential things crawling in windows. And I mean, that I can't stop thinking about that people can open your windows and animals might come in the windows. I don't even know how I would handle that. You've got all these other things as an IP to deal with, but now you might have animals just crawling right in your hospital through the windows. That just blows my mind.
The macroorganisms you got to worry about. It's not the micro ones.
Well, everyone's seen the Fight Club reference. You know, it's MRSA. It's like you're going in shirt off. Mm-hmm. And then, it's bed bugs and it's like full hazmat.
Yeah.
And when you're looking at again, going back to that attributable harm, who's really going to be most affected by a bed bug? Well, they don't live on people. They really kind of hide unless you're releasing those higher CO2 levels. Now, MRSA, well, that's pretty easy to move around and transmit and get infected by it. But again, it's understanding the micro, macro, and microbiology of all the fun things, biology of all the fun things that can cause problems. And then even looking at, as you talk about rodents can come in. One of the fun things that the residents love to look at are the squirrels that are running around outside and the birds that are using the feeders, but those are also a conduit for things to get into your hospital. And then thinking Hanta has been identified in rural communities. And so thinking about some of these other conditions that could be attributed from secondarily these pests that do come in our organizations.
With all of these opportunities, I'll say, it makes me think Dr. Paul Farmer, who was a TB epidemiologist, and I think his background was also in anthropology. So just looking at humans. He had a great book called Mountains Beyond Mountains. So what advice would you give to IPs where they've got a facility and it's not just one mountain, but you get beyond that mountain. There's another barrier, another obstacle, another thing that has to be changed. As we close out a phenomenal episode, what advice would you give to IPs that have mountains beyond mountains to tackle?
Well, I can definitely say it's a challenge. You have to constantly prioritize and reprioritize. What you think is your priority today can shift tomorrow. Really thinking about what is the potential harm, what is going on, and is this mountain more of a molehill, or is this mountain something like Mount Everest and you need to take a staged approach? You need to bring your oxygen. Also, don't forget, when you're flying on a plane, you put your oxygen mask on first. So you definitely have to think about what's likely to occur today. What is your capacity? Think about those quick wins, low-hanging fruit, something that can reduce risk the fastest. Is this potentially bringing in a vendor? Is this looking outside of the box? That box is not meant for you to be in it. It is meant for you to find the limits of it and climb over those walls. It's the long game projects. Sometimes it's small pushes forward. It's that 1% change. And you're not at this alone. You really need other people. You need your stakeholders to be engaged. These are a multidisciplinary approach, because just looking at it from one perspective, there's so many gaps. And I would definitely say prioritize without guilt. What your priorities are may likely be very different than what administratives, or even if you're working with multiple leaders, what their priorities are at that time. So sometimes even communicating why these are your priorities, why it looks like maybe I definitely can tell you I came into policies that are over 500 days behind. Is that my priority? I don't think so. Depending on what's happening, sometimes being out on the floor, talking to people, that's how you're going to really find some of what's happening and how you can solve these solutions. Because again, if you're working at a silo, you're going to maybe create a solution that doesn't fit either the organization, the culture, or that specific situation. Has so many little kernels, those little rocks, those mounds, those molehills that you're turning over. That's where you're going to find some of the kernels. You need to dive into that hole and figure out where it's going. And sometimes, yes, that rabbit hole takes you places you never expected. But at the end, you'll definitely find that wonderland.
Love that.
Well, Emily, we want to thank you so much for the insights you've shared and your expertise and just the candor of this. These are real world issues that every IP is out there dealing with. And I love that stepwise approach, the very realistic approach that it's sometimes the 1% wins that are going to get us to the finish line and getting to that wonderland. So thank you very much for what you do for patients, for IPs, and for the community. We appreciate you.
Thank you. And it's a pleasure to be here. And I wish everyone else an opportunity to just give yourself a break and just know that what you're doing and how you're doing it, it's one step forward. And just think about it's that 1 foot in front of the other that's going to get you to that finish line.
Well, every episode that we record, I have a little note card that I write notes and things I want to follow up on or learn more about. And my note card after talking with Emily Barnard is full. So great episode talking about the very real challenges that IPs are seeing in critical access hospitals and also how to navigate it without getting overwhelmed or missing that prioritization. So excellent conversation with Emily.
My favorite thing I wrote down from Emily's episode is this quote from her: "We don't really have a lane as IPs. We go into everyone else's lane." I think that's so true because we don't have a typical work day. We don't have a lane. We just have to do it all. And boy, does Emily do it all. We heard everything that she has to tackle on any given day. And just what an amazing woman she is. And of course, I loved her talk about the Gemba walk and just going into the Gemba, going to where the work is done. That's something that I have always done and believe in. That's where you're going to get your best solutions and your best action plans. So really kudos to Emily for making that a priority in her workday. Thank you all for listening, and we can't wait for the next episode. And as you anxiously await for the next episode, don't forget that infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.